Goel's Bariatric program, Center for Metabolic Surgery, Mumbai, brings a webinar on obesity and quality of life. We have had a series of webinars during the last few months, and we have tried to cover obesity in a holistic manner. We have spoken about the physical aspect, the treatment of obesity, exercises related to obesity, and multiple diseases like diabetes, hypertension, heart diseases, women's diseases, etc. And today we speak on the behavioral, psychological, emotional, and social aspects of obesity. We have a very experienced panel today to discuss this not so well understood topic. So the first speaker today is Dr. Kersi Chavda. Dr. Chavda is a consultant at Hinduja Healthcare Khar, PD Hinduja Hospital at Mahim, and Sir H.N. Reliance Foundation Hospital. He is the past president of the Bombay Psychiatric Society, and he has an experience of over 35 years. His field of interest is children, and he has been part of the first panel of the Maharashtra government that had laid down uh, concessions for learning disabilities, and he has also been on multiple other panels. So over to you, Dr. Chavda.
Thank you so much. It's always a pleasure to be working with Dr. Goel. For those of you who don't know, Dr. Goel and I are in one hospital at the same time, where he does an enormous amount of bariatric surgery. And quite correctly, because mental health plays such an important role in this particular phenomenon, we work as a team. Now, today I'm going to be speaking on a whole bunch of aspects related to the psychiatric issues associated with obesity. Following me, Dr. Gauri, who's a psychologist, will speak a little bit about counseling and about the various associated psychosocial and other factors that are also so important when we are dealing with obesity. And then Dr. Goel is going to come about with his magic mantras. What is so important about psychiatric association and obesity? We talk today of something called the obesity to the psychopathology pathway. And there are actual changes that occur in the brain structure when one is obese. There's something called sustained inflammation. There are endocrinal disorders. There is metabolic dyshomeostasis, which influence and compound each other. And all of that seems to be related to obesity. What then happens is it affects brain health, and it induces a regionalized inflammatory process called neuroinflammation. A little technical, bear with me, just 3 or 4 minutes. So when you have this neuroinflammation, which is regionalized and it is inflammatory, what lands up happening is that there is a functional and histological imbalance between the microglial cells and the astrocytes. Now we must remember that when the microglial cells overcome the astrocytes, you land up having an impairment of neuroplasticity. Now, the new magic mantra for neurology and for psychiatry is neuroplasticity of the brain. We believe that the brain is capable of regenerating, of its neurons not getting inflamed and actually producing new situations. It makes a lot of difference. So the important thing is that when this neuroplasticity processes get impaired, you land up having a problem with synaptic production, and then there are problems which occur in brain structure. If these problems occur in critical areas of the brain, you land up getting neurodegenerative processes, and you actually get scars of gliosis with a loss of neuronal cells. Not surprisingly then, depending on which parts of the brain get this gliotic tissue, we'll end up getting either depressed, or we'll end up getting anxious, or we'll end up having attention deficit disorders or eating disorders, and so on. So it is important for us to be aware of the fact that there are actual physical structures in the brain that get affected. Now, we know that many individuals with obesity also have issues related to their mood, their self-esteem, the quality of life, and the body image. Many multidisciplinary obesity treatment teams hence do and should have a psychiatrist and a psychologist on them to be more effective than others. Research has shown that weight loss is typically associated with improvements in psychosocial status and in psychosocial functioning. And the positive change is actually found the most in those who have lost the most weight. Some individuals who lose weight experience a return of pre-existing psychopathology or the development of new psychosocial issues. So, some people believe that I'm going to lose weight, everything is going to be okay. And then over a period of time, they find that that is not true. That maybe they don't have too many issues related to body image or things like that, but then they might land up having other issues. And this is something that is a continuum. So a huge amount of people with obesity actually have psychological or psychiatric disorders. Those who experience weight loss, those who experience weight regain, which often happens when you're doing these diets and things like that, you lose weight, you gain weight, you lose weight, you gain weight, remain very high at risk for the return of unwanted psychological symptoms. So what are the psychiatric issues that we are actually looking at? Probably the commonest one is depression. Depression seems to be related to obesity. People with extreme obesity are supposed to be 5 times more likely to have experienced an episode of major depressive disorder in their lives. So whether we like it or not, when a patient comes in with major depressive disorder, we actually also ask for eating. We ask for whether they eat properly, whether they're skipping meals, how they feel about their appetite, etc., etc. Because very often we also notice a bidirectional issue. When you're obese, the chances of you getting major depressive disorder is much higher than in the normal population. When you have major depressive disorder, the chances that you are more obese is higher than in the normal population if you are not having depression. This is more commonly seen in women, maybe because society wants women to be a particular shape and it's more important to them. And if you're looking at bariatric surgery, 1/3 of patients of bariatric surgery actually report clinically significant symptoms of depression at the time of surgery. So it is extremely important for all of us who are dealing with this issue that we actually have to rule out a depressive disorder at a pre-surgical level, so that then after the surgery, if for any chance the issues of the depression, the symptoms of the depression get accentuated, it is not taken as because the man or the woman had a bariatric surgery. It is taken that he already had a pre-existing disorder. What is the second most common? Eating issues. So we have eating disorders. And the commonest thing that we see is something called emotional obesity or emotional eating, where a person eats for emotional reasons. He or she finds it difficult to control the frequency of eating. He or she finds it difficult to control portion sizes. Very often we see that this is something that the person feels that this is the only thing I have control over. So let me eat. At least it gives me some kind of pleasure, some kind of satisfaction. Very often, we have hormones called ghrelin and leptin, which get affected in this. And the normal stimuli, which would tell me that my stomach is now full and I've got to stop eating, don't seem to function at that time, because the emotional high that I get associated in such a situation far overcomes these stimuli, which would otherwise make me stop. Emotional eating occurs in about 5 to 15% of people who eventually go for bariatric surgery. So this is again an extremely important psychiatric association of obesity. One of the common things again is something called binge eating, which, as most of you would know, the person eats a huge amount of food at a particular time, very high caloric content, and he does it in a very short time period, usually in 2 hours. One of the most famous people who used to do it was actually Elvis Presley. In my time, Elvis Presley, who was such a handsome guy, people were drooling over him, suddenly ballooned to 200 kilos. He would eat enormous amounts of junk food. He had a severe psychiatric problem. We are seeing a lot of that today as well. There is another thing called bulimia nervosa, just like in anorexia nervosa, where you don't eat and you try to bring up or you try to do some ridiculous amounts of exercise because you're so scared that you're putting on weight. You have something called bulimia nervosa, where you eat enormous amounts of food, just like in your binge eating. And then you do things because you feel so guilty and horrible and stuff like that. You either use laxatives or you try to induce vomiting, or you do a huge amount of exercise, which actually doesn't make physical sense. So eating disorders are very common. And there's a third thing which we also see often associated with obesity, and that is something called night eating syndrome. Now, what is a night eating syndrome? The person seems to be okay through the day, and then suddenly in the night, he can't stop himself from eating. He'll get up at 2 and he'll eat. He'll get up at 3 and he'll eat. He wakes up in the morning and he says, what is wrong with me? What is wrong with me? Why am I doing this? What is wrong with me, doctor? There's something wrong with me. I keep getting up and I keep eating and I can't go to sleep unless I eat and eat and eat. This is something again called the night eating syndrome. And it is certainly something very important that we see in situations where people are dealing with their obesity. So we've talked of depression and we've talked of eating disorders, the two most common psychiatric disorders. What is the third? Anxiety. If a person is suffering from severe anxiety, the chances that he is obese is also very common. As a corollary to that, if a person is obese, the chances that he's having an anxiety disorder, specifically social anxiety, is very high. Social anxiety, I mean, in kids, you have stage fright, where you can't get up on a stage and you can't declaim in front of a class. For an adult, obviously, it would be that I walk into a room and I don't know too many people and I freeze and I try to merge into the wall and I don't talk to anybody and I come and I tell myself, what is wrong with me? What is wrong with me? Social anxiety. Anxiety does have some kind of a bidirectional effect on obesity, though it's not as clear-cut as is depression. What are the others? Substance abuse. Substance abuse, 50% of candidates who report for surgery, for example, at the time of reporting would have some kind of substance abuse disorder. Very often alcohol, often smoking, and sometimes drugs. It just seems to be part of the same psychopathology that allows them to get into something which may be inappropriate for them to do. And as part of that same spectrum of disorders, they may also have obesity and other psychiatric illnesses. Something that people are not too aware of is that 16 to 32% of people report sexual abuse, both men and women. It's supposed to be much, much higher than in the general population. We don't really know what the cause-effect thing is, but we do know that there seems to be higher than normal sexual abuse. Maybe there's some grooming, maybe there's issues related to the fact that the only way that they can feel some kind of affirmation is to have a sexual encounter with somebody who then uses them and abuses them. But we do know that there's a higher than normal sexual abuse incidence in people. Taking all of that into account, it's not surprising then that they will have low self-esteem, usually. They have a very poor quality of life, usually, and they'll end up having major body image issues. And Gauri is going to be talking more about that. That comes with the realm of counseling and so on, and she'll talk about that. And we do use psychiatric medication at times, which maybe we'll talk about in the question and answer session. But the bottom line is that there are a huge amount of psychiatric illnesses associated with obesity. There's a huge amount of people who have obesity who land up also having psychiatric illnesses. So the bidirectionality is seen. A lot of people are not aware of the fact, but attention deficit hyperactive disorder, there also seems to be people, children and adults, who land up having higher than normal obesity, which is a little strange at times because a lot of the medication used actually reduces appetite. But there seems to be something over there that causes a kid and an adult who has problems with executive functioning, which is very often seen with attention deficit disorders, where you're more impulsive and things like that than the normal population. They'll end up having obesity issues. So this is again something that we look at when a person comes in for an assessment. If he's attention deficit disorder, we'd look at obesity. If he has obesity, we'd look at the fact that he might be having signs and symptoms associated with ADHD or ADD, which then might be an impediment in whatever be the treatment plan that we set up for the person. Evidence is moderate for anxiety. Obesity and depression have a very significant and a bidirectional association. Gender plays an extremely important role in these relations. There's another aspect that I want to talk about. Is there a possibility that some of our psychiatric medication cause a person to be obese? And yes, that is true. So if you're looking at antipsychotics, and let's be absolutely clear, if you have a major psychotic disorder, if you have severe schizophrenia, manic depressive psychosis, some of the other delusional disorders, you need medication. I mean, counseling might help, therapy will certainly make a difference, but I mean, it would be stupid for you not to be put on medication as well. It's like saying, I have a fracture of the hand, let me do yoga. That's not going to be effective. So if you're looking at antipsychotics, since there are a lot of doctors who will be listening in, the antipsychotics that are known to cause the most weight gain are clozapine, olanzapine, and quetiapine. The antipsychotics that are known to cause the least weight gain are aripiprazole, ziprasidone, lurasidone, and haloperidol. So if we are dealing with people who have a psychosis, very often we have to look at whether they're already obese, whether they're going to end up getting the metabolic syndrome, and so on. So it's extremely important for us to be able to diagnose, to be able to give the right medication, because we don't want to give them then an antipsychotic kind of medication, which will actually aggravate their obesity. Similarly, if you're depressed and you want to put the person on an antidepressant, the ones which cause the most weight gain are amitriptyline, imipramine, mirtazapine, and paroxetine. For those of you who are used to these medications, you must be aware that they can make a person put on weight. And especially if you are depressed and you suddenly start putting on weight because of the medication, very often you'll end up becoming more depressed. The ones that cause the least weight gain are fluoxetine, sertraline, bupropion, and vortioxetine. These are the ones which are known to cause the least weight gain. So again, if you're dealing with patients who are depressed and if they're underweight, put them on an antidepressant, which might help them increase their weight. They'll look better, they'll feel better. Metabolically, they'll be better. If they're already obese, be very careful about the antidepressant or the antipsychotic that you're putting them on, because we don't want to aggravate the situation. If we are looking at psychiatric illnesses, it is absolutely essential that obesity and features related to obesity and situations related to obesity be taken care of. They play an extremely important role. Metabolic syndrome is an extremely important issue that we see associated with psychiatric disorders, not only because of medication, but also because of the fact that the person might not be able to take his medication properly, might not take it regularly, might eat inappropriately, might eat only junk food, might not have somebody supervising whatever he's doing, might not want to do physical activity, etc., etc. Might have alcohol problems, might take drugs. So all of these can cause a greater increase in issues relating to obesity. Hence the necessity also of having a mental health evaluation for the same. I will now wind up and we move on to the next speaker. Thank you so much.
Thank you, Dr. Chavda, for covering, such a difficult topic in such a simplified manner. You have such a friendly and easygoing personality that I'm sure, patients would be very comfortable interacting with you. And many of Dr. Goel's patients also are, being managed by you. So thank you so much for being part of the webinar today. We'll be taking the questions in the end.
Yes.
Our next speaker today is Dr. Gauri Joshi. Dr. Gauri Joshi is a practicing behavioral trainer, personal counselor, and management consultant over the past 20 years. She has her private practice in Navi Mumbai, and she is associated with Center for Metabolic Surgery as a part-time counselor. She regularly conducts training programs for corporates on emotional intelligence, stress management, rational thinking, expectation management, behavioral modification, lifestyle management, etc. So welcome, Gauri, and over to you now.
Thank you very much, Dr. Madhu Goel, and I thank Dr. Raman Goel for inviting me on this panel today. I'll just share my slides to get started with my presentation. And yes, so we are talking about the quality of life with obesity. And first of all, what I would like to start with is, do all obese people need counseling, or are all obese patients victims of psychological problems? The big answer to that is no. Not all obese patients are going to have these problems, which you can see on my slide right now. So not all obese patients will suffer from low self-esteem or depression or anxiety attacks or mood swings or any other psychological issues. So, but these are the most common psychological issues or problems faced by many obese patients, if not all. As rightly pointed out by Dr. Kersi in the earlier presentation, we have so much of psychosocial context, a cultural context. There is body shaming. There is a lot of experiences in the environment which impact the way a person processes information and may get into any of these psychological problems. So not all obese patients are going to be victims of psychological issues. However, most are. And these are some of the most common psychological problems that obese patients will experience. I've picked up the most common ones. One is depression and one is anxiety. And you can see on the slide that these are some signs of depression and anxiety. So as a physician or as a GP, when you have a patient walking into your clinic for a blood pressure or a diabetes or any other symptom or ailment, as a doctor, you're also going to be on a lookout for these signs, which you can see. These signs on the slide are self-explanatory, so I'm not reading them out to you. But the sentiment I want to convey here is you're also a semi or a half counselor and a full doctor. So look out for these signs in your patients when the patients come to you with any physical ailment. So is the person looking completely lost, completely dejected in life, no enthusiasm, no excitement, and kaise ho, theek hai, chal raha hai, a very negative kind of response for the general questions that you may ask, and is getting into a lot of overthinking, and most of it is negative in nature, not able to let go things, a complete dejection in life kind of an attitude that comes across in your conversation with your patient. Let me draw your attention to the in you. But this is your clinical hunch as a doctor. You need to pick up these things. It will not be offered to you on a platter. The patient will never say, I feel committing suicide, unless there is a trust and a bond or credibility that has got established over years. So those are the signs you look out for, and you go by your clinical hunch. Now, what can you do as a physician if you have observed these or some of these or similar symptoms and signals, and you think that something is wrong and the person is not normal or not behaving in a standard format? So you look out. So what can you do? Observe. So the person is not even willing to look at you. While they're not expecting or staring eye contact, but the person is completely refusing eye contact. Is not the body language is stiff and very uncomfortable. So observe that person's body language. Observe the patient's behavioral indicators apart from the physical indicators that you will anyways be examining the patient on. Try and speak to the patient's family members to find out how the person is in his or her comfort zone. Does the person behave aloof, lonely, withdrawn in the personal setup also? Or maybe the person is just nervous, and or maybe the person is shy and reserved and is not opening up in the clinic. So solicit feedback about the patient's behavior by interacting with the patient's family members. Check if the patient is open for a conversation. For that, as a doctor, I'm sure you have your own creative ways of befriending your patients, both first timers as well as your regular patients. To check if the patient seems to be open for a dialogue. A simple way to check is you ask some very general open questions like, how was your day? What did you do today? What did you do yesterday? See if the person is responding in a monologue, just yes, no, okay, and avoiding to respond in a conversation format, or is willing to open up and is proactive in sharing more information. Sometimes doctors' clinics are very intimidating. It's sometimes just the air conditioning is too strong, sometimes the table is too long, sometimes the chairs are too plush and fancy. Sometimes it's just your environment that would intimidate a patient. So make sure that as a doctor and a semi or a half counselor, you're creating a comfortable environment for the patient who feels non-threatened and non-intimidated to open up to you if at all he or she needs help. And lastly, on this slide, before we go on to a few more, is patient listening, because sometimes we do understand doctors are rushed for time. You have a long queue of patients waiting to meet you for consultation. Sometimes time could be a scarce resource. But as a doctor who's interested in the well-being of your patient, dedicate some time, patient listening, positive body language, and probe if necessary. Apart from these things, as a physician, you could also do a few more things, like practice unbiased listening skills. Sometimes, either because we are in haste, or sometimes because we think we have understood what the problem is, or because we are so used to advising, because we are in that kind of a professional role that people seek professional advice from us. So we may just jump to conclusions. So as a doctor, practice unbiased active listening skills. I've suggested a small format over here. I've borrowed this format from a model called Karpov, a model of personal counseling, which is an offshoot of Carl Rogers' client-centered therapy. So the Karpov model gives us a very simple format which you can rehearse or practice, because it's a very good format to communicate empathy. The patient is going to feel understood if you're going to listen to the patient and paraphrase that you feel frustrated with yourself because you were not able to stick on to your diet and you binged in something unhealthy. So I say, exactly, that's how I feel. So the patient suddenly feels my doctor understands me so well, because you have summarized both the emotional content and the cognitive content of what the patient is wanting to and trying to communicate with you. Sometimes it may be necessary to involve family members. So that's again your judgment or your final decision. Assess the criticality. If you think that the situation is so critical that you're not sure if the patient is going to be safe, the patient might try to harm himself in some way. In that case, to protect your patient, you may want to involve family members into that discussion. But then again, that's subject to situation. In any case, if you plan to involve family members, you should always seek consent and obtain permission from the patient before involving family members. Finally, the last suggestion, what you can do as a physician in handling emotional or psychological issues with the patient is You are an expert in your domain, but you may not be an expert to advise medicines. So you need to guide or refer this person to a psychiatrist who is a trained professional to assess the psychological situation and advise medicines or drugs. So you may want to escalate this to another level if you think there is a serious problem that deserves or needs attention. Some do's and don'ts of counseling. As I said, all doctors or all professionals who are in this noble profession of saving lives are also counselors, though you may not be having a trained certificate that says you're a counselor, but you are a counselor, because the definition, by definition, counseling is a process of helping an individual to help himself, and each one of you is helping people to help themselves. So, as half counselors or semi counselors, these are some suggestions. Check if you have the time to get involved. Do not get involved halfway and step back, because that's going to do more harm than good. So get engaged or involved into a person's personal, emotional, psychological issues only if you think you will have the time to get involved. Because like half knowledge is dangerous, similarly half involvement could backfire. It could cause more trauma to the patient than otherwise. Express your interest in the patient's well-being. You will clearly communicate that you're interested in the patient's emotional well-being, not just physical. Sometimes this is an observation that doctors sometimes tend to multitask. So you're listening to the patient and you have this thing with you. So you're constantly also looking into your phone parallelly, or you have some staff member walking, you're signing papers. So we tend to multitask, which communicates disrespect, especially if the patient is taking a risk of opening up a personal issue to you. So please display very alert, attentive, undisturbed body language without any multitasking. Exhibit active listening skills and a non-judgmental attitude. All of us have our personal frame of reference. We all will tend to conclude or tend to assume or tend to interpret information based on our backgrounds, educational backgrounds, family backgrounds, religious, linguistic, communal, cultural. So that's the baggage we carry as human beings. All of us carry our own baggage. So non-judgmental attitude demands that you let go of that baggage and don't judge your counselee or patients based on your frame of reference. Please use rational thinking patterns. All of us are victims of irrational thinking at times, whether it is overthinking, whether it is generalizing, whether it is all or none principle, whether it is emotional reasoning, any kind of thinking pattern which is not backed up with a logical process is irrational thinking. So apply rational thinking patterns when you're dialoguing with your patient with an objective of extending emotional support or counseling service. Do not advise unless critical. Sometimes patients are just stressed out and they just want a safe sounding board to vent out. And they look up to doctors, and we all admire our doctors. So we just want to be heard. We just want to be understood. So it's not that every time you need to give an advice. Sometimes a respectful listening ear is all the patient needs. So do not advise unless the situation really demands so, or unless the patient directly, explicitly asks you for it. Similarly, do not comment or respond, because emotional catharsis, people just want to vent out their frustration. They want to feel understood. They want to feel empathized with. So they just want to let the steam out. So do not just cut them off or respond. Okay, this is what I think you should be doing. No, just listen. They just want you to listen and understand. So do not comment. Do not jump to conclusions. Patients who are emotionally disclosing a part of themselves to you feel vulnerable. They feel vulnerable because a very private part of me I'm sharing with you by telling you I feel scared, I'm feeling depressed, I'm feeling anxious, I feel nobody loves me. In fact, I don't even love myself. These are very difficult things to own up, forget in front of others, even to oneself. So if the patient is taking that risk to share something personal, emotional with you, the person is going to be very sensitive to your reactions. Even a non-verbal frown on your brow could put him off. Or even a simple thing like just looking at your watch could tell him, I'm not interested, you're wasting my time. So be very careful of the non-verbal gestures the non-verbal communication that you're sending out. 100 baat ki ek baat. Last and most important point, if somebody is disclosing something personal with you, a feeling or a factual situation, please respect the confidentiality and please respect the privacy of the person. You cannot go and badmouth or gossip or use it as a cocktail conversation or use it to make your conversations interesting. So please respect the confidentiality and privacy. And that same point overflows into my next slide also. As counselors, all of us take the oath of confidentiality. And as doctors, you all completely respect the patient's need for privacy. So there is absolutely, this is a non-negotiable value to not discuss the patient's emotional or cognitive issues in any other space. The primary goal of counseling is twofold: survival and happiness. So only when, as a counselor, I suspect that the survival goal of counseling is at stake, which means I think the person is suicidal, so I don't think his safety is assured, then I'm allowed to break the oath of confidentiality, because the person has to live the life ahead. So I'm more important in his life than in ensuring that I don't talk about it. So only in situations where my counselee is suicidal or he confides in me that I'm going to murder somebody, which does not sound just like a frustrated expression, but like a proper plan. So my primary goal of counseling is survival, and I can break the oath of confidentiality to save life of my counselee or of somebody else if somebody else's life is threatened. When do you decide whether we should speak to family members or you should let the patient and doctor have their own private conversation in the counseling space? How old is your patient? If your patient is a kid or a child or a youngster, then you may want to involve the family. If the patient is about 18 or about 21, 22, 25, if the patient is old enough where you think he can take care of himself, then that's one criteria. Overall, what is your impression about the general intelligence of this person? IQ or even EQ for that matter, emotional intelligence. If you, as again, your clinical hunch as a doctor, you are a pro, you are a professional, you decide. If you think the person comes across as intelligent enough, you may not want to involve family. If the person you think is self-confident and overall has a positive attitude, you may decide to not involve family members. However, for any reason, if you think the person's family members have to be involved, you cannot do so without obtaining the consent of your patient and saying, for these reasons, I think it is important to involve your family, and seek permission and then involve family. The biggest reason why we sometimes involve family members in counseling is because you're going back into an environment where you're going to be living 24/7. So your environment also needs to be sensitized or educated for what kind of support the environment needs to give you. So they are your primary caregivers, they are your support systems, they are your siblings, they are your best friends. You want to ask the patient to get his or her best friends. So whoever is the primary environment of the patient with whom the patient is going to live day in and day out, you may need to sensitize and create awareness so that your environmental system is able to support the patient in his journey. To close my presentation, I have got two small case studies, which I'm not going to read out in totality, but this is just what I want to share with you as a counselor, some cases I've been dealing with in the last 1 month. These are cases, two cases from July. So one obese patient who had this night snacking. I think Dr. Kersi has spoken about night snacking. And so these were the symptoms or complaints she came to me with, that high calorie daytime nibbling and night snacking, just eating when you're not hungry, or emotional eating. And the root cause, which in the counseling discussion we figured out, was a personal issue, that she had got out of an intimate relationship and she was not finding a marriage partner. The core emotions that the patient was surrounded with is things like low self-esteem, loneliness, anxiety, worry about the future, and an overall sense of frustration or cynicism. It was complete cynicism. And as a counselor, I help the person to stop judging himself or herself. So global rating is you judge yourself in totality. I'm worthless, I'm hopeless, I'm good for nothing, I can never do this. So this is a global rating. So instead of just criticizing your behavior of night snacking, you label yourself as a whole person as good for nothing, which further downs your self-esteem. So you educate the person not to do this kind of irrational thinking. Help the person to understand the difference between pleasure and happiness. So when you're eating high junk, high calorie food, you think it's making you happy, but you're actually not getting happier. You're only going to get worse because later you're going to get guilty. And that guilt is an SCP, a secondary emotional problem. So first you've eaten, then you have a secondary emotional problem. And you don't know how to handle the guilt, so you eat more. It's like that vicious cycle of what Dr. Kersi was saying, depression, obesity, obesity, depression. It's a similar thing. So you train the person to understand that this is only pleasure, which is short-lived. It's just for a moment. Your happiness is going to be to withstand that pressure and not give in to the temptation. That's actually going to make you happy. So help the person with some homework assignments, some reading assignments if the person likes to read, etc. And ask the person to come for a follow-up depending on the situation, maybe once in a week or once in 2 weeks or once in a month. I will stop with the second case study. This is the last case study I wish to share of an obese patient and a psychotherapy session I had with her last month. And again, she came to me with sugar addiction and mindless grazing and basically not caring for one's body at all. Total neglect of self-care, which again directly tells me as a counselor that it shows lack of self-love. You do not love yourself, you're not going to care about your body. There were other reasons because of which this happened, which we discovered in the therapy. And there was a personal problem, spouse had abandoned the family, emotional stress, financial stress, poor emotions. Now, meaningless again signals towards depression, a sense of meaningless, anger, and the treatment mode that we worked out for this particular patient was to look at self-awareness and self-regard. Emotional hijack is again a concept that is something to do with your amygdala part of the brain, which hijacks the thinking part, which is happening the cortex and prefrontal cortex. The oxygen supply is rushed to the amygdala part of their brain, and so your rational thinking is hampered for a moment. There's a little bit of science there. And I've tried to tell the patient to do self-control, self-regulation, reflective exercises, behavior modification techniques, which is basically reward the right behaviors and punish the wrong behaviors. And a follow-up which was recommended after a month's time. So I wish all half counselors here and complete full doctors here, I wish all semi-counselors here to extend their time for their patients. Your patients admire you, they look up to you. They will not listen to me, but they'll say, Doctor ne bola hai, so they will listen to you. So I wish you all happy counseling in the best mental health of your patients. Thank you very much. I stop my presentation here.
Thank you, Dr. Gauri Joshi. This was, beautiful presentation. And I'm sure after hearing, both the talks, there is so much hope and scientific and medical help available for everyone that people should be in a better state and to be managed. And the next speaker now is Dr. Ramen Goyal. Dr. Ramen Goyal is a senior bariatric surgeon. He's been doing laparoscopic surgeries for almost 30 years in JJ Hospital, Bombay Hospital, and bariatric surgery for the last 20 years. And his name is synonymous with quality care. So over to you, Dr. Goyal, for your presentation.
Thank you. Thank you, Madhu. So I think listening to these two experts in this field was an eye-opener because, my biggest problem that I had been facing with my patients is that we identify a problem and a psychological problem with the patient, and most of them don't end up going for help. So even though we may have a counselor in our bariatric program, they don't go for a counseling session. And as I was listening to Gauri Joshi's presentation, I could identify because, once I went for a session with a psychiatrist, and I could almost recognize the kind of apprehension even as a qualified doctor that I had in my mind. about the issues that that will come out, about the confidentiality, whether that will be respected. So I think for all the physicians who are here, these are pearls of wisdom, because if I can feel that for my first counseling session, and that continues to linger in my mind, whether that confidentiality will be maintained by my physician or not, it will be there in each of the patient who is walking in your consulting room. So I think psychological counseling, one, the patients don't want to get it done because they have the apprehension that it may not be their privacy and their views may not be respected, as Gauri nicely pointed it out. And the second thing is that they have to be given that confidence. And so I am happy that we kept this topic for the day. I'll start my presentation, and hopefully the slide should work today. Yeah. Okay. So as some of you know, I work at this Center of Metabolic Surgery, and we have been doing bariatric surgery for almost 20 years. And today we are going to talk about, I'm going to talk about how bariatric surgery affects quality of life or psychological issues associated with it. So what are these psychological issues and what is the evidence? And I'm going to talk mostly from the published evidence, because it's very difficult to evaluate impact of surgery in a very objective manner in our patients. So we do know how they benefit, and I'll show you some of those later. But at the moment, I'm going to talk about the evidence. So there are behavioral issues which can lead to difficulty in controlling food consumption and doing exercises. And that can lead to the onset and maintenance of obesity. Most of us know it, but there is evidence to that. There is a very important circle of discontent which goes with obesity. That when we eat high energy or calorie dense food, we know that this leads to obesity. And then we have the negative effect related to that, and that gives a body dissatisfaction. So we have a sort of unhappiness with our body shape, and that itself causes more negative effect. Itself causes more eating or consumption of energy dense food. So it's a circle which goes on, and it fuels further obesity, and further obesity fuels further dissatisfaction and more negative effect. So at some stage, people who are treating obesity have to break this cycle of discontent, and this is what we are going to talk today. And the question that was in my mind when we thought of this topic was, does bariatric surgery also address the underlying psychological condition that contributed to obesity? There are many factors which contribute to obesity. Psychological factors are also there in some patients. So we know how bariatric surgery helps in weight loss, how it treats comorbidity, but does it address the primary psychological condition that contributed to obesity? So just 2 slides about bariatric surgery. As we know, that bariatric surgery is for not in adolescents, but in obese people for 37.5 BMI and 32.5 BMI with comorbidities. These are the common procedures. The most commonest one is the sleeve gastrectomy. The next common is Roux-en-Y gastric bypass worldwide. And India, mini gastric bypass is also now very commonly done. So these are 3 procedures. I'm not going to talk about them today. But what we need to realize is what happens when a person undergoes bariatric surgery. How does that help, or how does that doesn't help? So one thing is that bariatric patients take longer to feel full or satiated. This is a study which was published in 2009, and this is compared to the normal weight individuals. So even though you have undergone bariatric surgery, your feeling of fullness come later than a normal person. and thus there is a possibility of consuming more calories. And in our program, which we have launched a portion control eating for last many years, which is and also published it internationally. This is probably the reason why portion control eating is so important, because if the feeling of fullness is coming late, then the person must restrict the food, the amount of food that you're eating. Then bariatric surgery also leads to certain change in eating behavior. So patients find in first year or 2 years that they don't enjoy sweet food or fatty meals. They are less pleasant for them. And thus they end up eating healthier food and they have weight loss. Now, these are all documented. It may be possible that one or the other patient may not agree with it, but that is anecdotal and this is evidence-based. So post-bariatric surgery, especially after gastric bypass, patients don't like to eat sweet food and fatty meals in the initial 24 months of surgery. Now, what is the impact of bariatric surgery on psychosocial health? Now, this has been documented that bariatric surgery leads to improved social relations, employability, and quality of life. But problem is with the people who already have pre-surgery depression, what Dr. Kersi and Gauri was mentioning, that if somebody has a clinical depression, it's not just because you are overweight and that's why you are depressed, but if it's like a disease. So those who have pre-surgery depression and anxiety, they are likely to lose less weight. And that is why these people need more help from counselors. They need to meet the counselor. They need to they need to lower their guards, and they need to meet the counselor at an early stage so that they can make maximum benefit of bariatric surgery. And then those who continue to have depression after surgery, it may affect their long-term outcomes in terms of maintenance of weight. So I think depression, as Dr. Kersi rightly mentioned, is more important. And in bariatric surgery also, if somebody is suffering from a clinical depression before surgery or continues to have it after surgery, it can affect results of bariatric surgery, and these people need help at an early stage. And there is nothing wrong about taking help. As I said right at the beginning of the program, I also sought help when I needed it, and I don't feel ashamed about talking to it. Why should anybody feel? The psychiatrists and psychologists are doctors, and when we have a disease, we should go to them. Then the question of eating disorders in pre-bariatric persons. So eating disorders, especially like binge eating disorder, which is seen in pre-bariatric patients in almost 10 to 25% of them. And then night eating syndrome, which Dr. Kersi mentioned, is also seen in few pre-bariatric patients. Now, these are matter of concerns because this is not normal. This is this is what is called as a eating disorder, and we need to be careful about that when we are doing a surgery in these patients. What happens to them after surgery? So binge eating disorder may persist after bariatric surgery, and this can lead to overeating or frequent eating, and that may affect weight maintenance. So if somebody is suffering from binge eating disorder and the person knows it and is coming for a bariatric surgery, they must speak about it with their counselor or their psychiatrist that I am undergoing a bariatric surgery, and let the counselor or the psychiatrist talk to us, and together we can help the person to overcome binge eating disorder. So it's very important that physicians who are listening to this talk should help the patient get professional help from a counselor or a psychiatrist so that the results of bariatric surgery improve. But what is seen is that night eating syndrome does improve after bariatric surgery. So we are talking of depression, which may continue. We are talking of binge eating disorder, which may continue, but night eating syndrome does improve after bariatric surgery. So we can differentiate where our patient stands. Now coming to the body image change. Now there is what is body image dissatisfaction? Why somebody is unhappy with the body image, because we say we should learn to live in our skin. So whatever it is good for us. But when the person develops a negative thought about or feeling about his or her body, and this dissatisfaction increases with BMI. So as the person is becoming more and more obese, the dissatisfaction increases. And this has been found as one of the key motivator for people who are coming for surgery. People do have comorbidities, people have diabetes, people have sleep apnea, but the commonest factor for which people come for bariatric surgery, one of the commonest factor is body image. And bariatric surgery does help them improve body image. And it becomes closer to what is socially accepted. Okay, so this is what is to be understood, that body image change is one of the key reasons for coming for bariatric surgery. And then what are the positive impact of bariatric surgery? So on body shape preoccupation, people are preoccupied that how I should be. There is a positive impact. The quality of life, satisfaction with one's appearance, all these have there are positive impacts, and these are all documented. Attitude towards one's body. But what one must realize, and what we as the physicians have to emphasize with our patients who are coming for help, that it reaches closer to the societal norm, but the person cannot become absolutely as the person perceives in his mind. So person may perceive that I'll be absolutely slim. It may not happen. So improvement may fail to reach societal norms, and this is what is one need to accept, and one need to make their patients accept. So body image improvements are related to change in behavior rather than actual weight loss. And this change in behavior comes with the help of our counselors. Each one of us, so as Dr. Gauri Joshi was mentioning, each one of us is 50% counselor or 25% counselor. Each one of us, whether we are family physician, we are nutritionist, or a bariatric surgeon, contribute partially in the counseling. And then we have professional counselors like her and Dr. Kersi Chavda and other people who should be engaged to help those who need professional help. So I think this is very important, that bariatric surgery is not the end of the story. People do need support, and they must be made to realize that there is no shame associated with reaching out for help. So friends, the challenge that I find after doing bariatric surgery for 20 years and treating obesity patients for last 20 years is, how does that the people have developed a behavior over a lifetime. Somebody comes to me for a surgery when they are 63-year-old. Surgery is a 2-hour episode. It doesn't change their psychology automatically. So how do I provide that psychological support which will change their behavior, which has been developed over a lifetime? And this is a challenge that I take it on myself, to my team, and I extend it to all the family physicians who get their patients operated and who see patients before surgery and after surgery, that this is not a one-time issue. These behavioral changes can only happen when we work with these patients and when we provide support to these patients in long run. We arrange these support group meetings on a regular basis. It was a quarterly basis. Now it has become almost alternate month virtual meetings, which is demanding things. I'll show you some of the quality of life changes which are not in terms of evidence, but like this lady who was in her 60s and was finding it difficult to walk from Mumbai only, could do a Char Dham Yatra with all the diseases. And now she said, I had never thought of doing it. And for her, this quality of life has changed in quality of life. Just to do a Char Dham Yatra is such a big achievement. This young girl who was 21-year-old when she had a surgery, lost 60 kgs, and now is doing her research and PhD in psychology in US, and married in is a big achievement from somebody who thought that there won't be any achievement in life in Mumbai. This young lady who is just 50, in her early 50s, became a career actor in due course, and after surgery, after losing weight, and is now doing multiple advertisements and films in Mumbai. This young man who was in a job chose to become a marathon runner after surgery, and is running all over the world in marathons. And now it is not necessary that each patient should become a marathon runner. Marathon is a sport. It's should be chosen by only those who are fit for it. But the fitness levels completely change. Again, another housewife who lost almost 50 kgs, even with the limited education, became a career woman and is a manager in a hospital in a place near Mumbai. Another lady from very close to where I work at Vocard now was getting a job like as a household help was impossible, because they will say, you are so obese, and how will you work? Just because of the obesity, the stigma associated with it, she was not even given a job for household jobs, and now she has lost some 50 kgs and looking to lose more, and is getting more acceptable. This lady who was on high dose insulin discontinued insulin within a short time, within 2 days after surgery. Just insulin itself is a quality of life issue, because when you sit down to have a meal, you need to check your sugar first, decide your insulin. You can't have a meal when you're traveling at middle of the night at 2 a.m. in a car on a dhaba. You cannot do it, because as a diabetic on insulin, you need to first check your sugar. So the quality of life is not a psychological issue. Quality of life is the way we live our life. This youngster who was about 130 kgs and lost weight and became a confident. Another young businessman from Navi Mumbai who lost some substantial weight and has decided to move on with life and started doing things. So this young girl who got married and has a child and a healthy mother now is a quality of life issue. A normal delivery, a healthy pregnancy is a quality of life issue. This lady who after bariatric surgery learned English so that she could follow our messages. She learned computer and she's learning swimming. Somebody who felt that she had nothing much to achieve in life is completely transformed it. So I think, friends, for me, quality of life as a surgeon is probably the biggest achievement that our patients gain. But I think the psychological issues are the elephant in the room that we must openly talk to our patients. We must encourage them to get this help, and we support them actively. So thank you so much, and I hand over to Dr. Madhu again to take the questions.
Thank you, Dr. Goel, for covering the scientific evidence and experience so well in your presentation. We have a lot of questions from viewers. The first few, are addressed to Dr. Kersi Chavda. Dr. Chavda, Dr. Gauri Joshi, in her presentation, she has partly covered this, question. Still, if you would like to add a few points, what should be the red flags for a general physician when, a patient who's come for other problems, how does he, decide or identify if they need psychiatric help?
Oh, okay. That's an interesting question. The bottom line is that whether we like it or not, 1 out of 4 to 1 out of 6 people will be having some psychiatric illness. So it's a good idea to have some quick, questions like, are you sleeping well? Are you eating well? Do you feel like crying? Are you motivated? Are you feeling very anxious? Does your heart go thak, thak, thak at regular intervals? Do you find it very difficult to concentrate? Do you find it very difficult to complete your task? Do you find that you're losing your temper too much? Do you find that you're landing up eating or drinking much more than what you normally should? Do you find out that you can't cope without taking a sleeping tablet at night? What we basically do is, depression is the commonest psychiatric illness. So ask some of the questions that you know are associated with depression. Anxiety is very common. So ask some of those questions. OCD is the third most common psychiatric disorder. So ask questions related to obsessive disorders, ask questions related to the compulsive behaviors that you might have, specifically related to the things that are happening in COVID, because, we're getting a little paranoid and then we're landing up doing too much checking, too much cleaning, too much of this and that, which may not be a bad thing, but can become bad if taken to absurd limits. So for example, 5 months into the pandemic, and today morning was dealing with a 17-year-old kid who's only been out once because he's just so terrified of going out. So that becomes an issue. Now, it is probably better to oversend somebody to a mental health professional expert for an evaluation and get a report that there's nothing wrong. About 20 to 30% of people who come to me, I look at them after evaluating them and I say, "Ho hum, you're boringly normal." But we should not miss out on somebody who actually would benefit with professional help. And there is absolutely no getting away from the fact that, especially in your, if you're a family physician, it is estimated that as much as 60% of the people who go into a family physician's clinic would be having some kind of psychiatric illness. And the manifestations of that are pains here and aches there and headache, and I can't sleep and I feel like vomiting. My neck is aching. I can't do this and I can't do that. So please oversend rather than not send, because then you'll be doing everybody a service. It's also a good idea for you, because most of you will be senior in your own life, to just go quickly through some of the signs and symptoms. You'll get them in any kind of psychiatric journal, or even on the horrible Dr. Google. You'll be able to find out things that you should be looking out for. And if you feel that your client is more than a few of those symptoms, it might be a good idea then for you to refer.
And briefly, could you cover, how does a family physician convince the patient that, they need psychiatric help?
Okay. So one of the things that I suggest is this. You're having all these symptoms, and we have evaluated you and we find that there is nothing really physically that seems to be a problem. If you're having a pain in your hand, the pain in your hand could be related to the fact that there is actually something wrong with the nerve or the muscle or the tendon or the bone. But it could also be related to the fact that because you're so stressed out, because you're so sensitive, people love being sensitive. So because you're so sensitive, there are things coming down from your brain and then they get stuck on that particular part of your body and you land up getting that pain. Now, whether the pain is related to an actual problem related to the muscle or bone or the organ, or it's related to something that's coming from your head, your pain manifestation is the same. So my recommendation would be, let me send you to somebody who will be able to find out if there is something that can be done to reduce the stress and reduce this extreme sensitivity that you have, so that your quality of life will become better. You won't have this pain in the future.
Wonderful. Now we have
lovely?
A few questions for Dr. Goel. What is the prevalence of obesity in our nation and the relationship of obesity with health-related quality of life?
Madhu, can you repeat the question, please?
What is the prevalence of obesity in our nation and the relationship of obesity with health-related quality of life?
So as far as prevalence of obesity is concerned, it is different in metros and rural area. So in urban area, the overall overweight and obesity together is somewhere about 60%. which is as high as what is in developed countries. But if we are looking at the rural areas, it's not even half of that. And that is why the total prevalence that we talk about nationally is somewhere about 32%. But that is not a true indicator of the issue. As far as quality of life is concerned, I am not aware of any obesity-related quality of life study that I have access. But maybe, I mean, Gauri or Dr. Kersi might be having any evidence about that. Not that I'm aware of. Yeah.
In continuation to that question, what can be the main reason for, the increasing number of obesity or rising obesity?
I think obesity is multifactorial. There is no way that one can identify one factor, and we have done an entire webinar on general obesity right at the beginning. So it could be, the common things that we love to blame, the junk food, lack of exercises. But there are many scientific studies which says that these are not the only culprits. So even home cooked food is a culprit in India. The environmental pollution is a culprit. Stress is a culprit. Lack of sleep is a culprit. So I think the what do you call the environment, the social environment, the number of marriages, parties that we do. So I think there is no way one can say why the obesity is increasing, but it has been identified that we have thrifty genes. India has lived through many droughts and lack of food. And so we have kind of genes which are like a sponge, which are ready to absorb food as it's become available. And with economic liberalization in early 90s, suddenly the economy of the country of lower class and lower middle class improved significantly. And that is probably the reason of this sudden explosion of obesity in last 20 years across the country.
We have some general questions. Has COVID-19 lockdown increased the cases of obesity and related comorbidity?
Yeah, I mean, we are getting reports both ways. So there are people who are saying, a good number of them, and you see all those cartoons being circulated on WhatsApp, that they have gained weight and they now can't move out of the lockdown houses and all. That apart, I believe families which have been cooking healthy food are now are seeing weight loss in their family members because they are not eating out. And families where the food is unhealthy at home are seeing weight gain. So I think there can't be a generalization. A lot of people have lost weight during lockdown. A lot of people who would travel and go to conferences, drink, eat, and all those things. So I think, and same thing is comorbidities. Comorbidities, I believe, have got better controlled because now the focus is so much on health. People are now, even lay people are talking of, they understand what comorbidity is. They are talking of zinc, they are talking of supplements publicly, openly. I think the health awareness level has gone up. I don't believe that the overall disease burden of the country has increased. It has substantially gone down.
And is body fat percentage a better indicator than BMI when studying health-related quality of life?
Certainly, body fat percentage and waist circumference, these are better parameters. But the issue is what is easily available. So the easily available is a weighing scale. So when you stand on a weighing scale and you divide it with your height square, you get your BMI. So BMI will remain the most applicable parameter of obesity measurement, even though one can have, a MRI measured fat percentage is the best parameter. But how many of us will undergo MRI every 3 months or every 1 year? I will never undergo that unless done for anything else. So I think applicability of a technique is more important than just what is the best.
We have questions for Dr. Gauri Joshi. Dr. Gauri, how important is it to measure the MCID, minimal clinically important difference score, for good quality of life?
I'm going to pass this question to Dr. Kersi. I'm not familiar with this construct.
Unfortunately, neither am I.
Okay, it
so
goes
maybe
back
we'll-
to Dr. Goel.
So, when somebody, I'm like a quite fair between these questions.
You have to de-jargonize some terms.
The person who is asking this question knows the answer. And we will be happy if they can educate us and educate the whole crowd. Please send the answer so that we can share it with others.
Or we can check it out and let answer them later. The next one for you, Gauri. How do social aspects of obesity play important roles in distress over obesity?
Huge. It's our social context plays a huge role in how we look at obesity and how we get distressed over obesity. So if I have to quote age-old psychologists who give us classic study of twins, that you give me two twins, I'll put them in two different environments, and each one I can groom him to become a doctor or a lawyer or a beggar, whatever I want, to talk about the role of environment. So the question about the social context takes us back into the debate of heredity over environment. So our social context has a huge role in our interpretation and we de-stressing over obesity. Having said that, since our social context is not in our control, it's wiser to look at what is in our control. So while I cannot go and put tapes on all people who are body shaming me and teasing me and bad mouthing me because of my odd body structure, I cannot do that. What I can do is to change the way I'm going to interpret this sensory stimuli and not choose to get affected by it. So yes, Dr. Madhu, the social context has a huge role in us de-stressing over obesity. But ultimately, we can choose to process the sensory information differently and not get affected into the negative psychological aspects because of our social context.
Okay.
If I'm permitted, I'll just intervene a little bit over here. I absolutely agree with what Gauri has just said. But there's a slight change now, in that old thing of nature, nurture, and we weren't sure about it. Everything now seems to be moving towards genetics. So there's an extremely important role now being played by your genes. So probably in the next 10, 15 years, we'll find that nature is actually, that your own genetics, your own insides are more important than your outsides. It's not yet been absolutely defined, but we are certainly moving towards that. Just by the way. Yeah.
Thank you, Dr. Chavda. And, can we measure those genes, or are there some tests available, or we are at
yes,
the
there
preliminary
are.
stage?
I mean, we are at the preliminary stage and they're insanely expensive right now. Just like we have genomic tests now, which actually would enable you to tell, to come to some conclusion as to whether one antipsychotic would work more than another for a particular person, or whether one antidepressant would work more than another for a particular person. There are also now movements towards finding out genetic things, which then would be able to kind of prophesy in advance whether or not you're going to have a psychiatric disorder.
Okay. The other one for you, Dr. Chavda, can different levels of psychological well-being have an impact on obesity in all children between 7 to 10 years?
I don't know why they're talking only of 7 to 10 years. Of course they can. I mean, if you have a kid who's between 7 to 10 and if he's being bullied in school or if he's in an abusive environment and he finds that the only thing that allows him to feel good is when he puts something into his mouth, obviously he's going to land up having some kind of eating disorder. Taking that into account, if he's very anxious, very upset, very depressed, and he deals with his anxiety by retching or by vomiting, which is a very, very commonly found thing, a commonly found symptom in kids who are very anxious and so on, then he's going to end up losing weight. But this actually carries on even in adolescence. We have a whole bunch of adolescent kids who land up having eating disorders and so on just because of the psychiatric or the psychological, or like Gauri was saying, the social things and the environmental issues, which are so very important during adolescence, where it is essential for the kid to feel part of a group. And if in that group he or she is body shamed or teased or bullied, he might just land up having an eating disorder, which might be obesity or one of the allied issues.
Thank you. Few questions for Dr. Goel. Does physical health outweigh mental health in obese patients suffering from diabetes, metabolic syndrome, or inflammation?
Yeah, so, physical health is more measurable. So the entire discussion on obesity or bariatric surgery remains confined primarily to weight loss, comorbidity control, and related issues. The psychological issues remain in background, though they are primarily stimulus why the weight gain happened, as Dr. Kersi just mentioned. Even in adolescence, the eating disorders find their way, and I think this is the unfortunate part of it, because of the measurability of something. Here we are looking on one side the blood sugar level, the BMIs, and on other side we are talking of palpitation and anxiety and nervousness. So they are measurable if the person goes to an expert and who are able to find out. But till that doesn't happen, they are definitely overshadowed by the physical health. Yeah.
How does the prevalence of asthma among obese individuals characterize the severity of impairment of quality of life and measure its relationship with pulmonary function?
Okay, so I think that's a complex question, but asthma is there for various reasons. But what we have seen is that patients who are coming to us, those who are asthmatic, have frequent attacks of asthma because they are morbidly obese, and the severity of attack is also more. So they have frequent attacks, and they require hospitalization more frequently than those who are slim asthmatic. And thus, once they lose weight, the frequency of attacks and the severity of attacks reduce. Asthma doesn't go away. Asthma remains there, but from having 4 or 5 times a year, now probably they have once in 2 years, and that is manageable at home. Now, how does it affect pulmonary function? We all know cor pulmonale, any chronic obstructive lung disease is probably the worst thing to happen. So long-term issues of asthma remain, and if the person comes early, then obviously those issues are overcome. And the patients who are coming with cor pulmonale, to be precise, are high-risk patients, and they have to be prepared very well for surgery.
Is bariatric surgery superior to other therapies as a management strategy for morbid obesity?
Without doubt. We are talking of morbid obesity. We are talking of people who are at least 25, 30 kg overweight. Anything can work. When I started my practice, people will come and say, "Inko neem ke patte pila denge pani ke saath and weight kam ho jayega. Why you are advising surgery?" So anything can work, but the thing is that how long the effect will last. So lifestyle changes in morbid obesity leads to sustained weight loss in only 2% patients. So initially everybody loses weight, but within 1 year they regain weight. 98% of them regain weight. And that is why bariatric surgery is advised in those people. We don't advise it on somebody who is 5 kg overweight. So I think there is no comparison. Bariatric surgery as on today is the only effective long-term measure for morbid obesity.
Thank you, Dr. Goel. The next one is for you, Dr. Gauri Joshi. Generally, for common problems like anxiety, depression, how many counseling sessions are advised, and what is the duration and what frequency?
So while anxiety and depression could be in different intensities or different levels, from very mild to right up to clinical depression, where I would pass on a patient confidently to Dr. Kersi, because a clinically depressed person needs drugs and psychiatric intervention and not just psychological talk therapy. So while there can be a range, it is not possible to conclude the number of sessions. However, I'm tweaking this question slightly in the context of obesity and related depression and anxiety. So a person can come for psychotherapy of, say, for 1 hour session once a week for the maybe first 3 to 4 weeks at least. And then depending on how well the person is coping, we can slightly wean it off to once in a fortnight, maybe once or twice, and then once in a month. So overall, it might spread over 6 to 8 months or maybe a year or more, depending on the intensity of the issue and the person's coping mechanisms. But as I said, if it is very severe, it would require medical intervention and drug therapy and not just talk therapy. So it would depend on the counselee's situation and his or her mental agility, toughness, ability to deal with, but few weeks at least or few months at least. 1 hour session once a week for a few months.
We have a few more general questions, but we have covered most of them in the presentations. So your concluding remarks now, Dr. Kersi.
My concluding remarks would be that obesity is something that we have to really deal with. We used to not take it so very seriously at one time. Very often it was considered to be, oh, if you actually try, you'll manage to gain control over your weight. Today, we know that people have tried and tried and tried, and there are problems. It is these new techniques like bariatric surgery which has caused a tremendous improvement in people's lives. And the connection between obesity and mental health cannot be overstated. So it is essential for us when we are dealing with any person and when we are looking at quality of life, that we look at both the physical and the mental aspects. Hence the necessity of looking at it in a holistic way. Hence the necessity of using multidisciplinary people when we are dealing with obesity. All the family doctors who are looking in should be aware of the fact that every obese person also has the right to be looked at by a mental health professional, and every person who's depressed or anxious should also be looked at as to whether or not there is obesity that can be dealt with, which would help both in a bidirectional fashion.
Thank you so much. Dr. Gauri, your message to the physicians.
Thank you, Dr. Madhu. My closing message to the physicians is that not all patients will have the luxury of budget and luxury of time and luxury of personal motivation to run around with 1,000 tests, which may not even be feasible or they may be too expensive, etc. But all patients do have the luxury of fine-tuning and reprogramming their minds, and their mental makeup, though, is primarily in their hands. But as physicians, each one of you has a huge thumping role in influencing their cognition. So instead of sitting back and critiquing on things that are not in our control and blaming it to metacognition, I think we need to look at what is in our control and bring about those changes. Something as simple as converting irrational thinking patterns into rational thinking patterns might solve more than half the problems. So my concluding message to the physicians is you are that one drop of the ocean which is going to make a huge difference to one of your patients. So choose your time intelligently. Go ahead, inspire, as Subrata Bakchi says, go kiss the world, and your patients will be grateful to you for the rest of their lives. So happy rational thinking, all physicians out there.
Thank you. So as I mentioned, today is the last webinar in, this series which we have been having for, the last few months, precisely the 11th one. And now I hand over to Dr. Goyal to sum up and, close the webinar.
Okay, thank you. Thank you, Madhu. So the idea is these webinars are not about bariatric surgery. Just because we conducted the webinars, we kept it. I always spoke out my profession at the end, because that's how I. Can you mute your? So this is very important to understand that these webinars for about obesity, about educating people, especially the family physicians, making them aware of how important obesity management is. You all know that, but it is becoming such a complex issue, because worldwide now obesity has become the second most common preventable cause of death after smoking. So are we looking at obesity with that kind of seriousness that it deserves? If we are not, then we are missing out on something that is affecting our country in a big way, and especially in bigger cities like Mumbai or Delhi. So I think that is one thing. Second thing is that on today's topic, obesity is not a willpower issue at all. Obesity has multiple factors. That is why the person is suffering. It's very easy to tell your son or daughter who is overweight that you should eat less, or you should go and exercise more, without yourself reducing the eating or exercising. So I think, and this is what we hear when we consult these patients, when these youngsters or even senior citizens, that their children tell them, Papa, why can't you eat less? Without realizing that this person has been trying to do it for last 10 years or 20 years of his life and is still not able to lose weight. So there are mechanisms, and there are techniques, and it is a real disease. It's very easy to say calorie in and calorie out, but that is not the end of the story. If this was the situation, each one of us have seen people in our own families who eat limited amount of food and they still gain weight, and we know so many of our friends who eat double the amount and still remain slim. We can very easily blame it on genes. I agree, anything that we don't know goes to the genes, but there are other issues. There are psychological issues. There is upbringing issue, the environment in which a person grows. So please stop blaming the person or stop blaming his willpower. If you have the courage, identify people who are slim and find out how many of them are exercising, and find out obese people, or find out how many of them are exercising, and you will realize that obese people exercise more frequently than slim people. So I think this requires a lot of introspection. Psychological issues are something which remain at the end of the whole obesity discussion, but this should be right at the top, because probably this is one of the most important contributing factor. Not because there is something wrong with them, but there are psychological issues that can be helped, and that can help in weight loss. So I think thank you so much for all those who have stuck with us for these 11 webinars. And these all webinars have been saved on the YouTube channel of CMS. So anytime we can share the collection of these webinars, because each of them has covered a different topic. And this is, I believe, a great repository of knowledge on obesity that we have created. And if we all come out of this pandemic, God willing, then I think many more people will be using this repository, this knowledge that we have created in future. So thank you so much. I wish to thank Dr. Gauri Joshi for her time and energy that she brings. I don't know how she has this tendency to avoid all the negative remarks that are not coming towards her, to absorb them. Do we call that a thick-skinned, thickening of skin or whatever? But I think those are the ways to live happy. And Dr. Kersi Chavda, who has been very willing all the time whenever I have asked him for help for various webinars, and he has always agreed to participate. So thank you so much. And then last but not the least, Madhu, my wife, who has been part of the team and part of the support system always to ensure the success. So thank you so much. And the Docplexus team, which has been giving us time each time, Dr. Kritika, Nitin, Jaldeep, and all others to make these webinars happen. So thank you so much. Bye-bye. Take care.